Welcome, Renee. I don't know if you can hear or see me.
Estira los dedos, cabrón. Oh.
Okay, Renee, can you hear me okay? I'm going to try to unmute you there, Renee.
I can hear you clearly.
Oh, good, good. Renee, where are you from?
I'm from La Paz, Bolivia.
Oh, okay, qué bueno.
Oh, you speak Spanish?
Claro que sí. Tengo un amigo, Marco Antonio. Él está de, yo creo, La Paz, Bolivia.
Ah, sí, en La
No,
Paz.
no, Santa Cruz, lo siento.
Marco Antonio?
Sí, Marco Antonio es un residente de Neurosurgery. Es aplicando ahora este último año de escuela en Bolivia, pero está aplicando a Ciudad de México.
Ah, ok.
Ok, yo voy a mostrar su perfil. Ok.
Ok.
Ok. ¿Tú conoces este programa de Zoom?
No.
Ok, yo puedo
Primera vez que lo
enseñar
veo.
cuando quieras. Yo acabo de regresar de Ciudad de México, hablando con una compañía de farmacia para arreglar un canal de medicina. Yo quiero.
بيصير الكونكشن مع فلوريدا.
Ujú.
إذا في أي أسئلة على صفقة القرن أنا مستعد أجاوبها.
والله يا دكتور حاول بتسوي بحث تشرح لنا شويه بس يعني هذا اهم شيء بس نفهم ما فهمنا ولا شيء من قد ما قعد يغمز الزلمه امبارح بس قاعد بيغمز
We'll talk later, Renee,
بس
okay?
نقول الله
Vamos a
يجازي
hablar más tarde.
السلمان والبحرين
Okay.
وبقية الدول العربية الفاسقة.
Ella va a empezar.
لما لهم دخل
Perfecto.
Y tú puedes hacer preguntas después de la presentación, René, ¿ok?
¿Está bien?
Sí, ok. Porque a él le gusta terminarlo antes de tomando preguntas.
Ok.
شيء؟ السلام عليكم مساء الخير. Good evening. My name is Ibrahim Sweih. I'm a neurosurgeon and we are transmitting live from the Farah Medical Campus here in Amman, Jordan to our international audience. This is Dr. Zaid Kilani, the founder of this institute, fine institute. The topic for tonight will be giant vestibular schwannomas, but with condition that they are severely invading the petrous bone. We'll discuss it from the clinical, radiological, operative, and pathological findings. VS means vestibular schwannomas for abbreviation. The classification, once you mention the classification, it is coined with Majid Sami from the International Neuroscience Institute of Hanover. This is Professor Sami. He was a friend of ours. He's a close friend of mine, of my family. We've been close friends for so many, many years. And this is visiting his center in Hanover. And this is back in 2000 in the University of Jordan. And here we are together in the WFNS. He was the president. I was the vice president. So the classification of Majid Sami depends on the size. Small size up to 1 centimeter, 1 to 2.5, 2.5 to 4, and larger than 4. So we speak of purely intracanalicular like this. See, this is nothing there. There is some enhancing, and it is small inside the internal auditory meatus. So purely intracanalicular. Here, like you see, it is filling the canal from here to here. So it's a grade 2. Grade 3, it has come into the cerebropontine angle, but did not touch the brainstem. 3A. 3B, it has touched the brainstem, but did not compress it. This is one patient of mine. 4A is compressing the brainstem. 4B is compressing and dislocating the fourth ventricle, pushing it. Grade 5, giant. It has crossed to the midline and it is large and giant. So this is the classification of these schwannomas. So we'll be concentrating on these giant vestibular schwannomas that are invading the petrous bones. Are they common? Yes. This paper 95, published in the Skull-Based Surgery Journal, and there is the Skull-Based Surgery Journal, and they're speaking about the atypical invasion of the temporal bone. Look at this. Not only dilation of the internal determinatus, but actual destruction of the petrous bones. Another paper from Korea, 2015, atypically invading temporal. You can see the temporal bone is totally destroyed with this tumor. Again from Japan, 2019, this tumor is invading the tympanic cavity and jugular fossa. There's no jugular fossa going this way.
Basically, it's a
Sorry?
Basically, it's the whole.
Yes, it doesn't usually, but this is the special subtypes of these schwannomas where they are causing this much destruction. So let's look at the radiology of this business. This actually is a photo I took when I was training at the Rotund Anatomy Center in Florida. This was the specimen I was working on, cadaveric specimen. It's beautiful. You can see the brainstem, you can see both vertebral artery, basilar artery, the ICA. This is trigeminal, and this is the internal determinatus on this side and on the other side. So looking at here, this special arrangement, there are 4 nerves that pass here. Facial, anterior, underneath it is the cochlear, behind it is the superior vestibular, underneath it is the inferior vestibular. So 4 nerves, 2 anterior, 2 posterior, facial, cochlear, superior, inferior vestibular. Concentrating on this side, again, you can see the facial, you can see the vestibular. Underneath the facial is the cochlear. This is, of course, the sigmoid sinus. Again, a magnified view showing you the relationship with the ICA. ICA is related to this group, ICA is related to this group, while the superior cerebellar artery is related to the trigeminal nerve. So this is the ear, this is the external ear, this is the tympanic membrane here, and these are the ossicles, and this is the semicircular canals and the cochlea, forming the inner ear. So if we look here at the inside surface of the left temporal bone is made of 6 parts. And if you add the ossicles, there are 9 parts. The squamous, the zygomatic, the mastoid, and so on, together with the tympanic and the stylomastoid foramen. So if we're looking at the inside surface of the petrous bone, you will find the internal auditory meatus. And the nerves are arranged like this. This is Bell's bar, Bell's crest. So 7th anterior, beneath it, lower, inferior is the cochlear, behind it, superior and inferior vestibular nerves. And the vestibular schwannoma, by definition, is arising from the vestibular nerve. It does not arise from the cochlear. So it will be arising from this nerve or this nerve.
Reminder for the residents, always 7-Up Coca-Cola down.
Good
7-Up.
to remember it. That's nice, 7-Up and Coca-Cola.
To remember.
So again, Bell's bar, again here, the facial nerve and the cochlear nerve, this is the other side, and so on. So, this is facial, this is cochlear, superior, inferior vestibular, and they have made a tumor. One of them has made a tumor. They would push the facial, they would push the cochlear. So facial weakness in vestibular schwannoma is not a common feature unless it is very late. So, if the superior vestibular nerve has caused the tumor, facial nerve would be this side. It is the inferior facial nerve will be this side. So facial nerve could be anywhere, but mostly anterior, anterior superior, or anterior inferior, very rarely posterior. That's why we would like to attack the vestibular schwannoma from posterior. We would love to know what is the facial nerve in all this. So this paper again from Majid Sami, 2011, they are doing this fiber tracking to see what is the facial nerve. You'd love as a surgeon to know where's the facial nerve when you are doing the surgery. This may be helpful, but not definite. Another paper from China, trying to track what is the facial nerve, and you can see it could be anywhere. Why I'm showing this? Because I will come to the point where people invented the idea of let's go and do surgery for these cases, partial decompression followed by gamma, which is ridiculous. So this is the imaging. Whenever you look at this cut, you know that this is the facial and this is the vestibular. So maybe this is the cochlear, this is the inferior vestibular, just the same. Just remember that. You would look at the internal determinators, and I'm saying as a تم التمساح is okay here, so it is not opening up, so it is normal. But here, you can see it's opening up, causing destruction. If you see cerebellum-10 angle tumor, people just think of vestibular schwannoma, which is wrong. Differential diagnosis is very, very wide. This is trochlear schwannoma, trigeminal schwannoma, induced nerve schwannoma. This is actually a case of mine. Facial nerve schwannoma, jugular schwannoma, or the three cranial nerves, glossopharyngeal, vagus, and accessory. Vagus nerve schwannoma, accessory nerve schwannoma, hypoglossal schwannoma. Just in time now for the differential diagnosis. Glioma presenting in the lateral recess, epidermoid, chondrosarcoma, chondroma, giant cell tumor, endolymphatic tumor. تفضل دكتورة.
السلام.
وعليكم السلام. Hemangioblastoma, meningioma, glomus jugulare, metastasis. This actually patient I operated upon, and I thought I was dealing with the vagus nerve schwannoma. And when the histopathologist gave me the report that this was metastasis, I went crazy. I said, are you out of your mind? This was attached to the vagus nerve, wouldn't the circumscribe? He said, this is a metastasis from adenocarcinoma of the throat. And indeed it was. Ependymoma, atypical ATRT, DNET, aneurysm, histiocytosis, cholesterol granuloma, endolymphatic sac tumor, medulloblastomas. People think of medulloblastomas only occurring in the fourth ventricle. They could go lateral. There's a special type called the lateral medulloblastoma. Lymphoma is always on the cards. So the differential diagnosis of a cerebellum-pontine tumor is very wide, and we have to think of all the spectrum so to make the good diagnosis. And what kills me is people treating these lesions with gamma radiosurgery without histological verification.
Thank you. My point exactly, actually, I requested to come to the podium to emphasize this very point. These cases, I can't tell you how many times would have been given a label of schwannoma and sent to STEREOTACTIC surgery, radiotherapy, assuming that schwannoma. And patients die later on, burying the evidence with them. These are actual cases. True, these cases look like schwannomas, but these are actual cases, and you can get a glioma, as Professor Specht has mentioned, with the mainstay of which, treatment of which would be surgery, to be followed by a laser-based chemotherapy, radiotherapy, or both. Chondroma, where the optimal management would be surgery. Chondrosarcoma, where really nothing works short of surgery because radiotherapy doesn't work, chemotherapy doesn't work, and optimal surgery is the way to go, not stereotactic radiotherapy. subjecting a patient to the knife without having examined them properly to rule out a possibility of a primary elsewhere, and burying the evidence with STEREOTACTIC radiotherapy is another crime that happens only too often. Histiocytosis, where they wouldn't have needed any surgery, radiotherapy, or chemotherapy. Medulloblastoma, where after optimal surgery, the mainstay of treatment would be craniospinal radiotherapy and, depending upon the age of the patient, of course, and platinum-based chemotherapy. These are actually actual cases. And worst scenario would have been lymphoma, where the treatment would have been high-dose methotrexate if it's primary CNS lymphoma, and treatment of the systemic lymphoma with intrathecal methotrexate or systemic methotrexate for CNS penetration, with no reason to do a total excision or radiotherapy. Actually, the reason why we give the chemotherapy is to attempt to delay the radiotherapy as much as possible in CNS lymphoma, because the consequences of radiotherapy in primary CNS lymphoma are worse than the disease itself. Now, I know that I'm preaching to the choir. We continue preaching to the choir on a weekly basis. And patients, when actually they have the intelligence of asking you, they'll ask you, Doctor, we heard about something called gamma knife. What do you say? And this actually happened to the very case that was referred by your doctor 2 days ago.
I had a chat with so many radiologists over the years, and I was dismayed that a good percentage of them think of them as describer. They just describe what they're seeing. They don't contribute to the differential diagnosis. I say a neuroradiologist should be aware of the classification of the schwannomas, should be aware of the so many pathologies there, and he would help me by saying, in T1, this is so and so, so it cannot be this. In T2, it looks like this, so it cannot be this, and come up with a short few items of differential diagnosis. So you are looking for 2 to 3 pages report. So what is the management of these giant ones? Obviously, it's surgery. Jekyll from the United States put this paper, selection of the surgical approach, whether you go translabyrinthine, labyrinthine, transcochlear, or posterior fossa, so many ways to reach to the vestibular schwannomas. I prefer the retrosigmoid. Last day from the United States, from Arkansas, again, use this middle fossa approach to reach to the same pathology. It's the surgeon preference. And these are the many authors that have managed to excise this tumor with surgical means. Again, you would wonder, would anybody in his own senses do any other treatment? You'll be surprised. So, again, surgery is needed, but you don't need this kind of surgery. This is a case that has been treated in the Arab world. This is the tumor, and the surgeon went this way, completely disrupting the cerebellum, the dentate nucleus, rendering the patient useless. Would you imagine that in the era of this microneurosurgery, somebody would do that? These are the mediocre surgeons that they have no conscience, and they should be treated as criminals. So microsurgery, I believe in the retrosigmoid approach that can deal with these giant vestibular schwannomas. It's practical with low morbidity. Am I saying this? No, the giants are saying this. Germany, Majid Sami, 2006, improved preservation of hearing and facial with the large giant vestibular schwannomas. Majid Sami again, 2010, 50 patients with giant tumors. 25% had poor function of the facial nerve, 50% with good. To preserve facial nerve with this size is almost impossible. So to get something like this percentage of facial nerve preservation is great. So the philosophy of Majid Sami, which he actually educated the whole world about it, me included, how to deal with these cases. All cases of vestibular schwannoma, irrespective of their size, Complete surgical removal, preservation of the facial nerve function should be the goal, not gamma radiosurgery or any kind of radiation for that matter. Another paper, new one, Majid Sami, recently, 2017, in the world of neurosurgery, giant ones with total radical excision. So don't listen to those mediocre surgeons that this is difficult surgery, it cannot be done. They are difficult surgeons, they are mediocre surgeons, that's why they go for gamma knife. It's clear. Large vestibular schwannomas from France, 2010, the complications of surgery. Of course, if you want to do surgery, you will have CSF leak, meningitis, hematoma, but these are minor complications in comparison with the cases I'm going to show you who have been treated with gamma knife. Management of large and rare vestibular schwannoma, 2011, from UK, from London, from Queen Square, one of the major centers in the world in neurosurgery. Again, the excision. So it's not one, it's not two. Many good surgeons around the world do this. And I choose to review this from India. So even in India, in the provinces, but they don't have facilities, they go and do radical excision. So don't take the argument saying, oh, we don't have the facilities, that's why we go for gamma. It's not acceptable. So let's come to the story of gamma radiosurgery for these giant tumors. How come? Short history, gamma knife radiosurgery started in Stockholm, 78. Next center was Buenos Aires, 81. Sheffield, UK, 84. Pittsburgh, United States, 86. Charlotte, Virginia, 87. And there are several models. Now the model we're using is, it's just like cars. They sell gamma knife like cars. This is Mercedes, this is whatever. We acquired the gamma knife in 96. I went to Sweden for 6 months and I brought the machine. But I knew from the very beginning, this is a tool. And I keep telling you that a fool with a tool is still a fool. So this is me during my training, and this is the certificate I got. So when I speak about gamma, I speak from the advantage point of experience. Let's see what's the concept of the gamma knife that was laid by Lars Laxell, the founder of this technique. He said, it is the delivery of a single high dose. Single high dose meaning that, how much is the dose of radiation that you give in radiotherapy? 50 grays, 55 grays over 1 month. Here you may give 55 grays or 20 grays within 1 hour or 2 hours. So it is delivery of a single high dose of radiation to a small, exactly.
50 grays in 1 month.
Yes. The conditions that it has to be small lesion and it should be critically located so that you cannot do surgery. So this was something to help us in those difficult cases. It became the concept of treating anything and everything with gamma knife. The indications, clear. Elderly patient with so many comorbidities, you cannot operate because of cardiac conditions, recurrent disease, you have done surgery, it came back again, you are allowed to have, but they introduced this and they are using it flatly. Oh, the patient refused surgery. He refused surgery because you give him the wrong information. Surgery opening your head and brain and blood, and so he would choose gamma knife. So they're using this as an excuse for their use of gamma knife, which is just to cover their inefficacies and incompetencies. So they started treating these tumors 3 centimeters or less. But they started treating this, 15 cubic centimeters. They knew very well that the outcome is poor, but they just kept going because it's money. You push a button, you take $15,000. There's no risk for you at all. So in the series published treating these vestibular schwannomas, they have the audacity to tell you, well, surgical excision is the first choice. Radiosurgery is an option. Nonsense. They went further. Oh, this is large. We know gamma knife is not going to do. So let's do what? Do surgery, remove part of it so that it becomes small, and then hit it with gamma knife. Other ridiculous kind of concepts. Because when you do that, there is high rate of recurrence. And already you have done surgery. You took all the risks of surgery. Again, they will take money for surgery, and they will take money for the gamma knife. And all lay papers published, almost all, the average follow-up is very short. If you remember in this hall, I told you about the current concept of malignancy after gamma knife, which is just like radiotherapy. It needs 15 to 19 years to develop.
And you did mention that the curve is not linear, actually,
It's not
it's
linear.
exponential.
Absolutely.
What happens after 15 years is that you keep increasing at exponential rate.
Yeah. One of the major centers from Bruce Bullock and Mayo Clinic, famous center for radiosurgery, published this paper 2010. Look at this. Number of tumors smaller, 16 out of 47. Number of tumors are smaller, 18 out of 82. I am a patient and you treated this with gamma knife and I'm still having this. What did you do for me? They say control. We have controlled the tumor, which is a bloody lie. Sorry, excuse my language. 2013, a paper again from Charlottesville, another center, where Steiner was there. I visited him many times. Again, this is before and this is after. What have you done? Brainstem is still compressed. They would say, we don't care about brainstem compression. So what do you care about? Unchained, decreased, very, very little patients that decreased. And they have progressed here and they needed surgery. So the whole concept is wrong. New permanent cranial nerves deficits, and there is death. They don't mention death in gamma knife. It can happen, and it happened many times. So, gamma knife radiosurgery for larger volumes, vestibular schwannomas from. No, it happens later. Yeah, but that's good for them because it doesn't happen when the patient is in hospital. So from Douglas Konziolka from Pittsburgh, again you can see before gamma, after gamma, and the result.
One cause of death, of course, is burying the evidence of an alternative histology, which is never documented.
Absolutely. What if that is TB or sarcoidosis? Yes.
Gamma knife, etc., etc.
So this is the list of patients who underwent resection after gamma knife. Poor patient paying for the gamma knife and paying for resection. Another paper, 2018. This is from, again, California. This is the tumor, you can see. First gamma knife, second gamma knife. They don't stop. They don't stop because it's money. There's no scientific basis for what they're doing. As I said, they went into, let's go and do surgery and then give gamma knife. So intracapsular decompression for radical excision followed by gamma knife. What a concept. Put the patient for the risk of surgery and then give him gamma knife. This is a crime, to say the least. Again, part 1 and part 2, management of large vestibular schwannomas by surgery and by gamma knife. Part 2, the same, management of vestibular schwannoma, surgery and gamma knife. Surgery and gamma knife. Tumor is still there.
Does it grow back real quick from those two procedures?
It can, of course. So the limitations of radiosurgery is the size. You cannot treat large volumes. They are treating huge volumes. And they invented another stupid concept, which is called fractionated radiosurgery. Not fractionated radiotherapy, fractionated. So you give gamma knife 4 or 5 times. If the tumor is related to the optic apparatus, you cannot. They are treating craniopharyngioma stuck to the optic apparatus. They don't tell us about the late recurrence because all their follow-up is short. And if you need to do surgery after the gamma knife, it's hell of a difficult. And the question of malignancy. As I said, there's always short follow-up of these papers. Let's see, can they have malignancy? Yes. I did not invent that. it is in the literature. A glioblastoma after radiotherapy for acoustic neuroma. Histologically proven because the patient had to have surgery. Radiation-induced sarcoma, large vestibular schwannoma. Sarcoma. This is from my clinic. South Korea, radiation-induced osteosarcoma after gamma knife. Temporal lobe gliosarcoma after gamma knife. Malignant transformation. It was a benign vestibular schwannoma and they turned it into malignant. How many years? 6 years after gamma knife. So the patient goes in, they put him in the machine, have the X-ray, bye-bye, thank you, alhamdulillah, astonishing. He did not have anything. Just straighten him. Don't say alhamdulillah, astonishing. It's too early.
Has there always been a histological diagnosis of the first tumor?
They should, but they don't.
No, I mean
in this particular, no. But you assume from the radiation. It was actually a schwannoma but turned malignant. Good question. This is my daughter. Malignant transformation of acoustic neuroma after gamma knife. Radiation-induced sarcoma. Absolutely طبعا.
ممكن كانت مش انه
ممكن جدا بس it's not coincidence لانه في عندنا حالات شفناها تحولت لمالجنسي, so you cannot ignore the evidence.
For example, the sarcoma of the second one, it would have been extremely unlikely for it to have been the case for 6 years. Patients would have succumbed to the disease much faster.
So this is 7 months after gamma knife. 6 years after gamma knife. Radiation-induced malignant nerve sheath tumor. Malignant transformation. Gamma knife, 6 years later. Secondary brain neoplasm. Another tumor would develop after gamma knife. Radiation-induced osteosarcoma, which we mentioned. Temporal lobe gliosarcoma, also we mentioned. And this is the list, which I took the trouble for you to look at what is being published of malignant tumors developing after gamma knife. The list goes on and on.
What kind of frequency is that? Okay, there's a list of, let's say you do 10. How many of those 10?
The published cases is something like 60.
Wow.
Now, I have to remember this, that for the early cases, there was a few number of patients treated with gamma knife. The number has increased in the last 10 years. So we do not know. And I will come to that because they say this is just the tip of the iceberg. This is bump in the road. No, this is the tip of the iceberg. Yes, of course. In the United States, many cases. No, not yet. If somebody is a very clever lawyer would make so much money. So these are the cases, and put them in terms of the years, 2014, 2018, 18, 19, and so on. So, yes, please.
Studying survivorship in oncology has been always a long time a passion of mine. And there's really nothing surprising in this. The only modality that is not associated with late malignancy in the treatment of cancer is surgery. Chemotherapy is associated with late malignancy, radiotherapy is associated with late malignancy. We had known that forever, including most of the studies come from Hodgkin lymphoma survivors, because those who survived the tumors and lived for decades after that, the survivorship literature, you're always looking at what happened 30 years earlier. And now we're understanding what we used to do, and correct me if I'm wrong, Dr. Sami, with the old radiotherapy techniques, not the current ones. 40 years ago, when, to answer Dr. Marwan's question, the incidence of mantle radiotherapy with the old techniques, the incidence of secondary breast cancer would reach as high as 30% at 30 years, which is so high akin to what you would find with BRCA1, BRCA2 malignancies. So part of those were radiotherapy alone, part of this was chemotherapy alone. With the advent of newer techniques, we would hope that things would be different. But the thing is, with every modality that is new in survivorship literature, and this is one of the problems in dealing with survivorship literature, you have to wait for 3, 4, 5 decades to understand what you did now, by which time the techniques would have by definition changed. But those are really interesting to know. Now, when you look at the late radiotherapy in Hodgkin survivorship literature, at 15 years follow-up, patients with Hodgkin start dying. The incidence of death continues to rise, but they start dying of other causes more than they would die of recurrence of their own lymphoma, including second malignancies. And the rate of second malignancies increases at an exponential rate, hence the 30 at 30 years and 40% at 40 years rate. It is true that these were all techniques, but now we understand what we did in the 50s of the last century. It is now that we do understand what we did. Right, Dr. Sami?
This statement, 2010, the risk of radiosurgery in these tumors may be higher than previously reported. People come to realize that this is the fact. It may be as high as 11.4%. The risk of radiation-induced neoplasm after radiosurgery may not be markedly different than that of that following radiotherapy. From Sheehan in Charlottesville, 2013. With the number, and this is my point number one, with the number of reported cases of radiation-induced tumors is already increasing, we expect to see a further major increase in the future. The number of cases treated in the 90s and in the first decade of 2010, etc., is much less than the one that was treated in the last 10 years. So this is definitely right. This is not a bump on the road. This is the tip of the iceberg. To that extent, that a center like this in Pittsburgh, Konziolka and Lansford, they say, at our institution, all patients who undergo radiotherapy or radiosurgery, they are told of the risk of developing a second tumor. They're starting to accept. What else? If they do gamma radiosurgery and it fails, which is usually the case, and you need another surgery, you need to treat them by surgery, then surgery is much more difficult. And these are the papers. And again, the master, Majid Sami. What does he say? Surgery after previous radiosurgery is most challenging and is related to worse outcomes. This man has done 4,500 vestibular schwannomas from all over the world. So when he says this, you better believe him. Surgery after gamma failure is disastrous. He says, in our series, which is the 4,500, all surgeries after failed radiosurgery were much more difficult. Why? You cannot identify structures. There is a scarring, no plane of cleavage. Nerves and blood vessels are very fragile, so you will get complications. So better tell your patient, if you have gamma knife and it fails, you are put in the corner. Again, the same thing from Majid Sami about these cases. And I wanted to show you one of the cases that I came across. I had many, actually, who had gamma knife and I had to operate on them. This man came from Syria, having had the gamma knife, swelling of the tumor. He became unconscious with brainstem compression, and we had to take him to theater as an emergency. And there's no structure that you can identify. It's very, very difficult. And this is the histology. So let me show you the video that it is really difficult to see details once they have the gamma knife. Gamma knife is a useful tool. It is something supplementary to what we are doing. But it should not be taken as a tool by the mediocre surgeons to treat anything and everything with gamma knife. I still refer cases for gamma knife. It is indicated, but not all the cases. So I just jumped through this. Here I'm opening the cistern so that CSF would come down. I want to identify the lower cranial nerves, which is the most important thing, vagus nerve in particular. And this is the tumor. Where is the tumor? Where is the brainstem? You don't see. And it bleeds and bleeds. You cannot see any plane of the cleavage. Here I'm trying to debulk the tumor from inside with the, and then go around it. And then I drill the internal determinators. I want to just to see some normal landmarks. So this is the drilling of the internal determinators. I'm just trying to find a normal anatomy to start there. You can't, you just can't.
Tumor?
That's the tumor, yes. Again, look at here. You can't see the plane of the cleavage. Extremely difficult. I just want to show you, to prove the well-known notion that surgery after gamma knife is disastrous. Look at the bleeding, look at, you don't know what the nerves were, all the same color, all the same thing. Okay. All right, okay.
Gliosis before?
Gliosis, adhesions, etc. So, let's see the histopathology. I've sent these to Dr. Fasach. Let's see what he has to say.
You can see in low power is cellular spindle cell tumor and very vascular, and there are some giant cells, and some of them they are lined together like in vertical bodies, we call them. But you can see a lot of fibrosis in other areas. Here you can see the cellularity is really increased, and you can see the fibrosis. Some of them look like collagen in some areas. And I found in different areas marked necrosis, and this is very unusual in usual vestibular schwannomas. Most of the time we don't see necrosis, and necrosis, if found in brain tissue or tumors, usually is considered an ominous sign. But probably this necrosis is induced by radiation, but was extensive, and that necrosis going to progress into fibrosis. You can see how much is fibrosis, very dense collagen fibers. This is called glassy collagen. We see this in usually secondary to radiation. And you can see very, very hypocellular. This looks like cement. And this is more areas less cellular. You can see changes that usually secondary to radiation, that cells may become hyperchromatic and degenerated. And they may become ugly and hyperchromatic, but usually this is not a malignant. Usually this is a change that we see in secondary to radiation. Some areas will be less myxoid, and this is Antony B in the area. But you can see how much hyalinization, much more that we expect just for usual schwannoma to see hyalinization. And it's known that radiation will increase the intimal, fibrointimal proliferation for the blood vessels. You can see more hyalinization and probably some occluded blood vessels because of so much fibrointimal proliferation. Again, you can see the cellularity here, and most of these cells, they are really more ugly than you expect for the usual vestibular schwannoma, and this is expected in radiation changes. Because of the histology, this immune was essential. We did S100, and S100 was positive nuclear and cytoplasmic staining, indicating a neural origin of the tumor. So this was vestibular schwannoma that has so much changes, probably secondary to radiation.
Dr. Barbisa, does that answer your question?
Yes, sir.
You know now why it is more difficult. The adhesions, the fibrinization, and the hyalinization. So this is the final diagnosis. My series of these, since I started documenting these large cases, 90 till 2018, 664 cases, less than 4 centimeter, 592, more than 4 centimeter, 272. And this is what we are reporting here. So this is the number. I had 1 mortality, I had 7 morbidity. Facial nerve preservation is poor, 10 out of 72. These giant ones, you rarely be able to save the facial nerve. We do them in the sitting position with navigation and cranial nerves monitoring. And this is just some of them. They are really giants. Exactly, exactly. And whenever I show these slides abroad, they say, oh, so what is the current situation of medicine in Jordan? How the people would reach this? I say, these come from other Arab neighbor countries. So they could be cystic ones, cystic schwannomas. They're really giant and invasive. Look at this one. These are real cases, not from books, but from my personal series.
So is that necrosis that back?
Yes. Let's show you some of the videos that when you operate on these, how the color is okay, how the discrimination of brain of the cleavage is okay. So sitting position, this is the left side, this is the right side. The retractor is retracting the left cerebellum, and I'm trying to here identify something. But you can see color. You can identify colors. So I did
The 72 were actually treated with gamma knife previous to surgery. Were any of those 72 cases?
Yes, about 11 cases.
No.
So debulking of the tumor, we say debulk, dissect, drill. Debulk, dissect, and drill. These are the message that I'm conveying to you, which I took from Professor Sami. By the way, my daughter Asid went and had a lecture period with him and she learned a lot. So this is the causa. Now I'm trying to identify the facial nerve. Mind you, if you identify and preserve the facial nerve, this does not mean that the facial nerve function will be present. Just touching the facial nerve, just pushing it may damage it. So we depend on the signal from the cranial nerve monitors. But you can see the plane of the cleavage. I'm taking the arachnoid towards the cerebellum and brainstem. Difficult, yes, but enjoyable because you're doing the right thing. Here I'm incising the dura around the interdictomatus so that I can drill it.
Are they invasive or are they well encapsulated?
They are well encapsulated, are benign tumors. So this is the drill of the internal meatus. Again, I want to see facial nerve here. I want to see facial nerve here and try to preserve it in between these two spots here. I'm taking the tumor away from the facial nerve. But you can see some plane of cleavage. And those treated with gamma, it's not. So here's the facial nerve from the brainstem side. I've seen the facial nerve from the interdictomatus. I'm working in between these two. And the worrisome is that when the signal of the facial nerve stops, so you know that you've lost the facial nerve.
So, if you touch the facial nerve or pressure it, usually temporarily, but it takes time.
Yes, of course, of course. But what I wanted to say, absolutely, what I wanted to say, Mahmoud, is that the facial nerve is so sensitive that even if you touch it, it can damage it.
Sometimes when we put the back into the ear.
Absolutely, absolutely, yes. So again here, just to proceed. So here you are. This is the trigeminal nerve, this is the abducent nerve, and this is the facial nerve. Okay, let's see another one. And again, you can see the cerebellum is quite relaxed. Not like the image which I showed you where the surgeon went through the cerebellum and chopped it off. Another case, this is on the right side. Again, the same principle, debulk so that you can go around. Now I'm seeing the tendinous meatus and the facial nerve from the bone part. It's a tedious thing, but you see structures, you're trying to do your best here. Again, here drilling of the intent. It's the same procedure like we have seen. We'll stop this one. It's the same procedure like we did with the first case.
So if you do a total, or let's say pretty good debunking, your reoccurrence rate is what kind of?
If you remove it completely, the recurrence rate in the same place is 5%. That's when you remove it completely. So, some of the illustrative cases before surgery and after surgery. Again, this is the large one I showed you. This is before surgery, after surgery, with good function of the facial nerve, before and after. All patients, they would have the MRI the following morning, which is usually 7 hours after surgery. We never put a patient on a ventilator, never, ever. Here we managed to, this was actually treated in the West Bank, and they have left this tumor. There's usually a cyst around it.
Treated by gamma knife?
Yes, in Israel. Here you can see before and after surgery. And same thing, look at the destruction of the petrous bone. This lady from Yemen with this tumor postoperative. This young girl from Turkey. And this Iraqi girl, which I think I presented this here under this roof. A very sad story. Iraqi with this large tumor. She went and had first surgery. I will not mention the country. And this is the small piece that they have removed, telling the patient, we have removed it completely. Oh, let's go after 2 days to remove the rest of it. They have done nothing. So let's go for gamma knife. Of course, no gamma knife here. We went for surgery, excised it, and this is the girl presented to her husband and son. The last case, very interesting, is a patient, Jordanian patient who works in, he used to work in the Jordanian TV, still alive, with this very destructive kind of tumors. Look at this. Again, you can appreciate the size and the compression in the brainstem. Look at the bony destruction. So this is really invasive, and this is just a collection of pictures. This is on the left side, as we said. As we open it, these are lower cranial nerves. This is trigeminal and so on. So let's see it in video. I'm about to finish, so I kept my promise of doing this under 1 hour. Again, the tractor holding the cerebellum. We have drained CSF here, so we don't really put any pressure on the cerebellum. And this patient was extremely lucky that the tumor was just underneath the facial nerve. So this is the fascia. So all this petrous bone was invaded by the tumor. I'm here opening the tumor underneath the fascia, debulk it. This is the facial, this is where the tumor was, and this white structure there is the trigeminal. And this is the flash of camera to take still pictures. So this is the trigeminal with the superior petrosal vein or vein of Dandy. The lower part of the tumor is being debulked. Again, you can find the plane of the cleavage. This man was extremely lucky. I was extremely lucky that I did not face problems with this man. Here, draining more of CSF to make the cerebellum relax. I want to see the vagus nerve, the glossopharyngeal, and the accessory. I'm interested in the vagus. Damaging it will put the patient on a ventilator for many years. Excising the tumor, debulking. So this is the picture. This is the cavity within the tumor with the petrous bone. This is the facial nerve going to the internal pituitary canal. This is the trigeminal going to Nichols cave. Lower cranial nerves. Lower cranial nerves. The cavity in the petrous bone. Facial nerve, reducent nerve, trigeminal nerve, lower cranial nerves. Trigeminal going into Nichols cave. This is Nichols cave. This is the facial. Separating facial from cochlear. So yes, we preserve this. Doesn't mean that the function of the facial nerve is there. Most of the time, if you preserve it anatomically, it will be preserved from the physiological point of view. And this is the post-operative with a long follow-up of 7 years. We did not have any recurrence. And just to remind everybody with the discharge summary that we do, which is a detailed discharge summary. I'm proud of it because we have been doing a good job for the patient, for his GP, for the referral patients. For if you die, the patient has all the documents that he has. With this, I finish and I thank you. Any questions, any comments? Please. Dr. Farid Al-Adam.
I think what you show us this story of is the story of the truly lack of or shortage of good skull-based surgeons all over the world. Because even in institutions where you showed, if there is a very good skull-based surgeons, they would never be doing these kind of radiosurgeries. So it is fascinating how few of you exist in the world, and it's affecting everybody all over the world. I don't know how to solve this problem, but because the places where you showed these studies of radiosurgery, they're not doing it for money. These are people who are having on a salary basis and whatever it is, but I think it's because of shortage of good skull-based surgeon, and I would like to hear your comment about it. Second of all, it is truly amazing to see how many you did of this. Almost 600 of this. I'm almost certain there is very few people in the Middle East who even close to half that number. So it's something to be proud of as Jordanians to have that expertise, and we hope that would continue in the future. The last thing I want to comment on, can you comment, you showed that the preservation of the facial nerve in these large ones is relatively low in your series. How does that compare to the rest of the world? Are we above, below, the same? Thank you.
And answering to the last point, it is within the range of the others. With large, giant vestibular schwannomas, the chances of you preserving facial nerve is low. So we are with the same current status. The answer to your question, is this because we have a few small numbers of skull-based surgeons around that people go for gamma knife? The answer is no. Skull-based surgery is just a step ahead of the general ordinary neurosurgeon. The drilling of the internal determinators is in the domain of any average neurosurgeon. But they don't want to do it. They don't want to know the anatomy. They don't want to bother about anything. I use the drilling with the enteroclinoid and sphenoid vein. People say, wow. I say, what wow? This is in the domain of anybody. Just people don't want to learn. And if they learn, they want to. It's easier for them to send it for government. So I don't think it is because of short number.
To that point, the places where I worked, there was, they say when I trained, there was 11 neurosurgeons. There's only one who was doing that.
And everybody was referring cases to him.
That's how it works.
Yes, sure.
So,
دكتورة.
بعد ذلك العمل المدن الجراحي الذي تقوم به، طبعا أنت ترسل التقرير بعد الجراحة، ترسله عمدا للجراح الذي هل سبق واتصل بك واعتذر أحدهم؟
Never. To tell you a story. I was sitting. I will just finish this afternoon. I was sitting in my clinic when somebody knocked the door, and it was a patient who had surgery in one of the hospitals around. He was a Yemeni patient, and he said, "I had surgery for vestibular schwannoma." He's well educated, but I'm worse. And the surgeon doesn't want to do post-operative MRI, and he wants me to go to Yemen and come back in 6 months' time. I said, well, I cannot help you. You have to have post-operative MRI. So he went and had his MRI in another hospital without the other surgeons knowing it. He came to my, and you could match the tumor before with the tumor after. I was diplomatic. I said, well, there's still some pressure there. You need another surgery to clean the rest of it. He went to his surgeon, and to my surprise, he phoned me. He said, how dare you tell the patient that I did not do a decaying session? See the audacity, the low level of people? He said, you should have told the patient I've removed the tumor completely. Let him go to Yemen and come back, and I would tell him that it recurred. These people are criminals, and we should expose them. Any other questions? Question.
After you have removed the tumor, why did you have to separate the patient?
So you went to
Arkansas.
Arkansas.
Yes, thank you, sir. Yeah. So why did you have to, let's say, jeopardize and put some pressure on the facial nerve by separating it from the cochlear nerve?
No, this is normal. This is routine part, and you can handle it, but you have to handle it gently. Yes. Okay. Well,
how much of the percentage of vestibular schwannoma with the cochlear?
Recently, you can preserve the cochlear nerve.
No, in the there is a cochlear schwannoma or no?
No.
No more.
No.
Or what we used to call it, of course, the neurology.
It's a misnomer. Yes, it is vestibular schwannoma.
How many gamma knife apparatus in Jordan?
One, and there is another one that's going to be implanted in University of Jordan. We don't need them because the number of cases that are yes, the one that I brought from Sweden. As I said, the number of cases for their proper indication is very few, but these people are for after money and not for the scientific reasons. Thank you very much, and we'll meet next Wednesday. Thank you.
Thank you.
في محاضرة ثانية معي حركات يعني
Hi, Dr. Sabeh, can you hear me okay?
Yeah, I can.
Oh, great. Another excellent multidisciplinary presentation. For the panelists that don't know, Dr. Sabeh has been doing these for 27 years, multidisciplinary. Anyway, Stuart, I believe you have a question. I'm going to unmute you there. Go ahead, Stuart. Stuart, you there? Oh, I'm sorry. Let me unmute him. Sorry about that.
No problem.
Stuart, are you there? He mentioned he had a question. I can perhaps ask him for it. Oh, we have no audio. I'm sorry. Okay, let me ask for him. Okay. In the experience of in your experience, have you found the same anatomical characteristics in the surgery as Dr. Samil described?
Yeah, of course. I'm proud to say that I've learned the surgery for acoustic neuromas from Professor Sami. So all his education points are highlighted in every case I do. The principles of debulking of the tumor from inside, going around it until you see the plane of cleavage between the tumor and the brainstem, and then go and drill into the meatus so that you can see the nerve starting from there, and then work in between. So these are principles that are, stood the acid test of time.
Okay, that was from a neurosurgeon in Ecuador, Stuart Portillo. We have another question from a Peruvian neurosurgeon. You think it's better not to do radiotherapy for a small residual tumor because of malignant transformation?
No. As I said, I still refer cases for radiation, but it has to be really indicated, not like the cases that I've shown. So to me, gamma knife is a good tool, but in the hands of mediocre surgeons, it tends to be really a criminal job. So there is a place for radiotherapy and radiosurgery, but not the spectrum of cases that they have been treating. So if I operate and there is a residue, I would wait. I would not jump on radiotherapy. I would wait and see that this is really progressing, and then I may give radiotherapy or radiotherapy.
Okay, very good. Adnan or Ali, do you have any questions or comments for Dr. Sabaya? Perhaps not. Okay, Dr. Sabaya, thank you very much. And what's the topic for next week?
Well, I have not decided yet, but I will shortly.
Okay, we'll keep in touch. Thank you very
much.
Thank
you very much indeed. Thank you. Bye-bye.
Bye-bye. Okay. Stuart, can you hear me? I guess you can't hear. You can just see, I guess. Hi, Adnan and Ali. We're off the air now. So we're not, although we're live on YouTube. So be careful what you say. Stuart, can you hear me or no?
Just yes, I can.
Oh, okay. Well, I got to ask you a question.
The problem is the more noise here.
Oh, okay. Well, you'll be able to see the recording and you'll be able to see his answer.
Okay, thank you so much.
Yeah, it'll be posted.
Okay, great.
So how's everything with you, Stuart?
What?
¿Cómo está?
Everything okay. Todo bien.
Okay. Good. Okay.
Mucho ruido afuera.
¿Tú estás en hospital?
No, en casa.
Oh, okay. Ruido. Okay. Okay. Adnan or Ali, are you there? Can you hear me? Adnan or Ali, are you there? I'd like to meet you. Oh, maybe not. Okay. Okay, Stuart, I'm going to end this, okay? I'll see you later. See you later.
Yes,
Bye-bye.